Good morning, Dr. Omofoye.
How are you?
It is so lovely to have you on this interview. Thank you so much for taking time out to join us. Could you kindly introduce yourself?
So, my name is Toma Omofoye. I am a breast radiologist and associate professor of radiology, and I practice in Houston, Texas.
Well, it's so lovely to meet you. I've heard lots of wonderful things about you, and it's an honor to have you on this broadcast. So I see that your research interests are global health and the imaging of breast cancer and breast diseases. Can I ask how you came about to choose this career?
Well, I think global health chose me, first of all, and I think it chose me before I even had decided if I was going to be a physician or not. I was born in Nigeria, but I was born to two physician parents. And so it was very clear how much of a need there was for health care and how much of a need there was for people to participate in health education. For a long time, I considered doing public health or even healthcare journalism. But eventually, when I got to medical school, I decided on breast radiology, and it's been wonderful to be able to participate in breast radiology locally and around the world.
Wow, that's fantastic. That is a real contribution to the field of oncology. So thank you very much. It's definitely better. The field is better off with people like you. Diagnostic radiology uses non-invasive imaging scans to diagnose disease. Can you further describe the whole concept of diagnostic radiology, what it entails, the technology used, and the efficacy in diagnosing breast cancer?
Oh, that's a wonderful question. It's very broad. I'll try to do it justice. Diagnostic radiology is taking use of medical imaging, so x-rays, CT scans, MRIs, those sorts of technologies, to take pictures of the inside of the human body. And based on this very large body of knowledge, when we have those images of the inside of the body, we can find the patterns that are characteristic of different diseases. And we're able to diagnose a lot of diseases just based off of imaging in a way that people couldn't do 50 or 100 years ago. But part of what is so wonderful about diagnostic imaging is that we also have the ability to, in some cases, actually confirm diagnoses by doing biopsies. For some disease processes, when we see the images and the characteristics that should, leads us to suspect that that particular disease is present, we are able to actually help confirm whether that it's truly a case of that disease by performing a biopsy. In the olden days, if you needed a biopsy to confirm a disease, somebody had to be taken to the operating room and a surgeon had to perform a whole surgical operation in order to get a sample of the tissue to send to the lab to confirm the disease. And then it meant that this patient had gone through the surgery, the pain of that, the healing process, even the cost of that. And often that's just step one because that's just the diagnosis. Now you still have to go through the whole treatment paradigm. So I loved how smart diagnostic radiology and interventional radiology were, because now using images, I can go with an ultrasound machine over the exact spot that I see the abnormality. I can take the tiniest little needle, make a tiny incision, get a sample out, send it to the lab in a way that's much more comfortable for a patient, much less worry of healing difficulties, less costly in a lot of cases, and starts the process of that patient being able to get treatment. It's funny that in a lot of cases for us, especially in breast imaging, when we are diagnosing breast cancer or breast disease through biopsies, our patients are awake and we're talking with them and we know them and all of that. And the patient will often ask, okay, have you started? And I'll tell them, actually, this is the end. We're done now. So it's wonderful to be able to take care of people in a way that feels humane and feels really gentle and smart and leverages technology to be able to improve health while minimizing damage.
Yeah, fair enough. And it's amazing how far it's gone, from 50 years. To ask a question, because Infiuss Health focuses on clinical trials in Africa because we're interested in the best of medical intervention, the best pharmaceutical products coming to Africa so that African patients have access to the very best, the most developed technologies that are out there. So in your practice, do you see differences in patients' anatomy or physiology? Do you see differences in the incidence or prevalence of breast cancer? If you compare the typical African American to the typical Anglo American, are there differences that you've noticed?
That's a really interesting question. And in fact, there's a third piece there. Is there a difference between the African in Africa, the African American, or the Anglo American, right? There's that whole spectrum. And the truth is that we find that breast cancer in African American women and in women of African ancestry tends to be diagnosed at a younger age. So there is some difference. We just don't have all the answers as to why. Interestingly, also, the African American women and the women of African ancestry, we find have a lower survival rate from breast cancer compared to the Caucasian counterparts. Some of this is very confusing. Some of this is, these are areas of current research that we're trying to figure out how exactly to improve health outcomes for these subgroups. But there appears to be some difference in these populations. One thing we know is that a particularly more aggressive kind of breast cancer called the triple negative breast cancer, a version that can be a bit harder to treat, is more common in women who are African American or of African descent. So there are some differences, I think, in the biology of these groups that leads to a lot of questions and a lot of areas of current research in trying to improve health for women everywhere, right? To give a fair go at health equity. For women in these groups, it becomes even more important that we work very hard towards early diagnosis. So in Africa, for example, we know that 70% of breast cancer cases are diagnosed at later stages 3 and 4. Which is very, very different from a lot of the high-income countries, where majority of cases are diagnosed at the earliest stages. What I want everyone to keep in mind is that breast cancer is a highly treatable disease, especially diagnosed in the earliest stages. For the earliest stages of breast cancer, they respond to treatment very, very well in most instances. The 5-year survival rate is over 90%, pretty high. It's something that's highly treatable. And so when we lose the opportunity to diagnose it in the earliest stages, we are really placing the burden on a longer course of treatment that may not be as successful. You're going for treatment now that's more extensive, maybe multiple regimens, takes longer time, and still may not be as efficacious as the treatment that we're able to implement in earlier stages. So the early diagnosis piece is especially important. And while we may not have all the answers about biology and the differences in subgroups, we do know that early diagnosis improves outcomes for everyone across the board. So that's one thing we always want to emphasize is how can we communicate one-on-one to women everywhere that all women have some risk, especially women who are African or of African ancestry. All women have some risk. And so you want to always be thinking, how can we implement early diagnosis? Beyond that, we also, I think from the industry perspective and from academia, we want to do all that we can to provide access to people so that the people who are trying to come in for screening exams or come in the first time as soon as they feel a lump, they have the opportunity to have early diagnosis of disease as well.
Thanks for the explanation. That's very interesting that you see differences. I wonder if you also see differences in the response to treatment.
I will say that because I'm a diagnostician, the treatment piece is not as much as my work or purview, but there is some data suggesting that there may be differences in the treatments that are offered. Now, not necessarily one-on-one, but if you're looking at large population groups, that there may be differences in treatments that are offered to African American women versus white women. And the data has suggested that African American women were more likely to receive treatment that was falling outside of the guidelines. So they may have had shorter courses of treatment or more interruptions to their treatment, certainly longer delays before beginning treatment. And all of these cumulative effects can contribute to poorer mortality on that group as a whole. So, the treatment piece, the response, I think I would have to defer that to an oncologist, but certainly we see that overall the outcomes from treatment are really not even at this time. We really want everyone to be able to take advantage of medical advances in a way that helps to prolong life for all of us and really helps us to be here for our families.
Just another question. Do you observe any epidemiological and risk factors of high-risk breast cancer patients?
Oh my gosh, this is such a great question. Thank you for asking this. If there's one thing that you take away from this, anyone watching, let it be this. There are differences that can confer higher risk for developing breast cancer in certain groups. And two groups that we know have higher risk for developing breast cancer are Ashkenazi Jewish women and Black women. So women who are African or of African ancestry do tend to have a higher rate of the breast cancer associated genes, the BRCA1 and BRCA2 genes. And they have higher risk than over a lifetime of developing breast cancer. A lot of times when you speak one-on-one with patients, they'll say, well, breast cancer doesn't run in my family. I don't know why this would happen to me. Every person, every woman has some risk of developing breast cancer, but we want to be especially careful when we're talking about women who are of African ancestry or Ashkenazi Jewish descent, because there is a likelier, a higher risk in those populations a lot of the time. So we want people to know that they have opportunity way before anything pops up to go ahead and assess their risk. It's something that we offer at our institution. You can have a meeting with your physician to estimate your risk of breast cancer. And we do this because we have solutions. So if you have that estimation done and you're found to be above a 20% lifetime risk of developing breast cancer, there are lots of options of treatments that you could engage in. For some people, it means that they would just undergo screening more frequently. So they would have 2 screening exams a year, a mammogram every year, and an MRI every year. And they would typically stagger these 6 months apart so that every 6 months they're getting screening. So you have the opportunity to get screening more frequently with more modalities. You have the opportunity as well, depending on the cause of that elevated breast cancer risk, you may be eligible for some medication that can help to reduce that risk over your lifetime. And then for some people whose risks are really, really high, like some of the women who have these genetic mutations, they may actually consider performing mastectomies, just performing mastectomies before a breast cancer has a chance to grow. And it was in the news, a few years ago when some high-profile actresses had undergone mastectomies for these reasons. But there are always options when you know your risk. So it's important that people are empowered to know that whatever we find, we will find an option and a solution to help address.
So in your practice, what would you say were the safest and the most effective methods of diagnosing breast cancer through radiology? And what would you consider the advantages and disadvantages of the methods?
I think that is a great question. The truth is that mammography is one of the safest and best imaging modalities that we have, especially for diagnosing breast cancer. It's not exciting. Women don't often want us to talk about mammography because they associate getting that mammogram done with having their breast put in the machine, and there's compression and there's some discomfort for a few seconds. But mammography has been proven over and over and over again to find breast cancer at its earliest stages before it can be felt, when treatment is most effective. And we know that the cancers that are found on mammography tend to be smaller, easier to treat. So mammography has actually been linked with decreased mortality in breast cancer. And if you think about it, that's pretty remarkable. There's not a lot of tests for a lot of cancers. And even for the cancers who have tests, we don't necessarily have the robust evidence associated with it saying that it decreases mortality associated with the disease. So mammography is our workhorse. We respect it. It's really important that we continue to encourage people to undergo annual screening mammography. Now, in addition to mammography, there are other options. So women may undergo ultrasound examinations as well. That's because for some women, mammography is beneficial, but the way that their breasts are structured are so dense, is what we refer to it. They're so dense that smaller masses may be missed on mammography. So in those women, they still have to undergo mammography, but they have the option of also then undergoing ultrasound for additional screening of the breast, or they can undergo MRI. Now, breast MRI is a very, very sensitive test. It's different from the mammogram where you come in, stand, get your pictures taken in even 20 minutes. The MRI is a bit more involved. So you come in, you have an IV placed, we give you some IV contrast medication into your body while we place you on a table in the scanner, the big donut scanner. And it takes much longer time to take images of the breast, because here we're not just taking pictures, we're actually taking images to see how that injected contrast interacts with any potential masses in your breast. So we might see lots of masses. Some of them may be cancerous, some may not be, but it's a much longer study. It is a very, very sensitive test. But it's much more involved, right? We're talking now in a situation where somebody has to have contrast. They have to be able to tolerate being in the machine. It is not easy for people who are claustrophobic. It's a longer amount of time for that examination to happen. And it's more expensive. And so MRI is something that we tend to save for cases where women are high risk, or there's some other question that needs to be answered by this more sensitive but more expensive testing. So we always prioritize mammograms. And in fact, we continue to critique ourselves in mammograms to get better and better at them, to modify them in ways that help us to detect breast cancer even better than we have in the previous years.
Wow, that's fantastic. That sounds like you have three different options and kind of choose one for each special case. So each kind of patient that comes through and with special needs can either go through mammography or the MRI.
Yeah, and I would say for most of our patients, we really say we start with mammography. I would say 99% of patients. And then the question is, do we add on the ultrasound or do we add on the MRI? But the mammography for 99 to 100% of patients is really the most beneficial first step.
Would you think that there are new and upcoming advancements in the practice of radiology for detecting breast cancer? Do you see that happening in the near future?
Absolutely. Absolutely. I mean, those of us who go into science, we are nothing if not stubborn. And so we're always trying to be a little bit better. There are lots of exciting advances. I'll say, we had mammography initially, and then over the last couple decades, we added on tomosynthesis, which is sort of a 3D mammogram that could be added on to your usual mammogram. And that helps us, especially with the patients who had denser breast tissue that's more likely to hide small masses. But even beyond that, more recently now, we're going towards contrast mammography, which allows us, similar to the MRI, we inject contrast into the patient, and it goes through the body relatively quickly. But while it's going through the breast tissue, we take mammogram images of that tissue because that contrast can help any masses in the breast to, become more prominent. So it helps with the diagnosis of breast cancer. So contrast mammography has probably been the big new thing for us in the last few years. And there's a lot of excitement about ways that this could be beneficial. Some patients cannot tolerate MRI, for example. And so being able to do a contrasted exam with mammography may allow those patients more options for their screening beyond a standard mammogram. So lots and lots of exciting technology all the time.
Yes, and that's why we're here. We're here to advance newer technologies and newer therapies for the advancement and the betterment of patients. So the final question, what piece of advice would you give to any woman that's listening or reading or this video with regards to her health, about the screening or diagnosis if she's already been diagnosed, or screening if she hasn't, and just taking care of her health with regards to breast cancer?
Yeah, that's a great question. The first thing I would like every person to take away is that every woman has some risk of developing breast cancer. Every woman. In the United States, the risk of developing breast cancer is 1 in 8 women. So it's relatively common disease. But beyond that, what I want people to know is that the sooner it is found, the easier it is to treat, and the more likely that treatment is to be successful. So I don't ever want anyone to be paralyzed by fear or worry. We would ideally like to be able to find cancers before you can even feel them through participating in annual screening mammograms. But if you do feel something, or your dog feels it, or your partner or your child feels it, it is important to come in as soon as possible. So I like to say by 2 weeks, you need to have an appointment to come in, right? Really as soon as possible to get that checked out. Not all of those things that are changes to your breast, lumps or changes to the skin or changes to the shape, changes to the nipple. Not all of those things turn out to be cancerous, but it is important that you come in as soon as possible. And then I think what I want to say to the women who have been diagnosed, and really to all women, is that there are always options. I think that we continue to make advances in science, in diagnosis, in treatment, in management of breast cancer. And so we want people to always stay engaged. It's important that you find doctors that you trust and then you follow their recommendations. And if you find that that really is not working for some reason, or, you're running into issues, come back to that doctor that you trust and say, let's find a different option. We really want patients to feel empowered. We want to be teammates with our patients. We want to be teammates with all women. We want to be teammates with their families because everyone has different goals. So stay in communication. Let us try to leverage the best of technology for your benefit.
Thank you so much, Dr. Omofoye, for your wise words, and want to say thank you for taking the time out to be here. Thank you very much, Dr. Omofoye.
Thank you. You're so kind. Thank you for getting the word out about breast cancer and all that you do to try to improve healthcare for people all over the world. So thank you for having me.